being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press star 0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator for today, Ms. Maria Judd, Senior Director at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Judd.
Thank you, and a very warm hello to everyone on the line with us today. We're bringing you today our new on-call series from the Better Together campaign, Spreading Family Presence Policies to Accelerate Healthcare Improvement. I'm Maria Judd, a Senior Director for Patient Engagement and Improvement here at the Canadian Foundation for Healthcare Improvement, CFHI. And I'm just thrilled to be your host today as we present this first session in a series where we'll focus on changing the concept of families as visitors to partners in care and quality improvement. We're joined by a fantastic group of speakers and also 288 registrants from across the country. As I take a few moments to introduce our guest speakers, please take a moment to introduce yourself in the chat box, who you are and where you're from, and share with us as we go through our webinar today any questions that you have that come up as we're sharing our experiences. That's on the bottom right-hand side of your screen. So we're just absolutely thrilled to be joined today by Bev Johnson. Bev is the President and Chief Executive Officer of the Institute for Patient and Family-Centered Care. She's over 25 years of experience in organizational development and management. She's worked as a health professional, providing direct care in hospitals, managing a hospital unit, and teaching. She's she's someone who's known to many of us across the country as a real inspiration and leader for how we partner with patients and families for care that is truly patient and family-centered. We also have with us today Dr. Costello, who is the Acting Facility Medical Director at the South Health Campus and also a clinical assistant professor with the University of Calgary. Also joining us from Alberta is Joanne Ganton, who is the Executive Director of Engagement and Patient Experience in the Quality and Healthcare Improvement Division of the Alberta Health Services. She works with a team of professional consultants and engagement experts to engage the organization, patients, and families on a journey towards excellence in patient and family-centered care. We're also joined by Angela Morin. Angela has been partnering with healthcare professionals providing input in policy and facility design, quality improvement, and program development as a patient and family experience advisor since November 2011. She currently sits on both the Kingston General Hospital and the Southeast Regional Cancer Centre Patient and Family Advisory Councils, as well as Accreditation Canada's Client and Family-Centered Care Advisory Council. Angela is also a faculty member and coach with CFHI's Partnering with Patients and Families for Quality Improvement, and she sits on the Board of Directors at Health Quality Ontario. And last but certainly not least, we're joined by our staff member Christine Micah, who's an improvement lead here at CFHI. Here's our plan for today. We're focusing on changing the concept of families as visitors to families as partners in care and allies in quality and safety. We're going to start by sharing a case example of family presence policies at Alberta Health Services. We're going to describe family presence policy trends in hospitals across Canada and look at the steps that can be taken to establish a policy that supports patient and family-centered care in your organization. We're going to explain and explore how family presence policies can serve as a mechanism to improve the patient experience and outline the benefits for patients, families, and staff of implementing such policies. We're going to introduce you to some best practices shared by leading organizations that have already implemented family presence policies. We're going to share with you some upcoming opportunities and existing supports for organizations who are embarking on this journey. And we'll hear from a family member about what the difference this makes. CFHI is an independent organization funded by the Government of Canada, and we're dedicated to accelerating healthcare improvement for Canadians. Our mission is to help accelerate the spread of proven innovations by supporting healthcare organizations to adapt, to implement, and to measure improvements in patient care, population health, and value for money. Today, we're focused on spreading the innovative policy of family presence policies that enable partnerships to improve the experience and outcomes of care. We'll be coming back to family presence and its connection to quality in the latter half of the presentation after we hear from the team at Alberta Health Services South Campus on what this policy can look like. But to start, so we're all on the same page, we'd like to share this definition with you. Family presence policy and practice enables patients, if they choose, to designate partners in care who are welcome in the hospital with them 24 hours a day. Practice elements can include family as defined by the patient, the opportunity to identify preferences for how the family will be involved in care planning and decision making, and ensuring that families are welcome 24 hours a day, including opportunities to be involved in daily interdisciplinary rounds, shift changes, codes, and other emergency situations. So without further ado, it's my pleasure to turn things over to Joanne Ganton and Dr. Del Castillo to share their experience of their journey towards patient family-centered care and the role that family presence policies played in that with us. Over to you.
Hi, and thanks for the opportunity for us to speak about some of the work we've done at the South Health Campus. So the South Health Campus is a hospital that opened in 2012. And so one of the things that you'll hear during our presentation is that we had the advantage of starting from scratch. And when you start from scratch, you can embed a lot of PFCC policies and procedures right from the beginning, but you don't necessarily need to start from scratch to be able to do some of this work. So a little bit of introduction about the South Health Campus. We're built on a 44-acre greenfield site, basically meaning that this was a farmer's field a few years back, and now it's a fully operational large urban hospital. We have 269 inpatient beds, a 30-bed emergency department. I'm an emergency physician, so that's my home when I'm not doing medical administration. We see about 65,000 visits through the ED. We have 12 operating rooms. We have a fairly large outpatient facility that sees about 130,000 outpatient visits per year. We have 2,500 births, 3,200 staff, and of that, 180 are physicians. And so you can see on the slides here a picture of the South Health Campus plan. So phase 1 is in the red box. That's what's currently built, and then there's plans in the future for phases 2 and 3, which is outlined in the yellow box. Again, we're a large urban hospital. We don't have any real subspecialty programs at this point in time, but as you can see, we have a large range of services, both in our acute care programs and our outpatient services, including all the way from pediatrics up into geriatrics program as well. So like I talked about earlier, we did have the advantage of starting from scratch, and we were able to embed some of the PFCC principles right from the beginning. We started out with some visioning forums in around 2007, 2008. Bev Johnson was part of that and instrumental in establishing PFCC here at the South Health Campus. As part of those visioning forums, probably the most valuable thing we did was citizen engagement. So we have a citizen advisory team that's made up of about 30 members from the community who right from the beginning in 2008 were part of the planning process. And really we heard strong and clear from them that they wanted to have a voice in making sure that the South Health Campus was built in such a way that PFCC was a really important part of the process. And then again, we embedded their feedback and a lot of the PFCC principles from the literature into the planning and construction of the site. So the citizen advisory team was really important in that, really brought the voice of patients and families. A lot of the members of the team have chronic illnesses of one sort or another, or family members with a chronic illness. And again, they really help to inform the design of the facility, not only the facility itself, but also some of the culture that we've built into the South Health Campus. Like I said, Kat was there right from the beginning in the construction phase, so we would often take them on tours. We did a lot of mock-ups of our rooms and did various scenarios. So I participated in a mock-up emergency department design phase where out back in a trailer here we had members of our citizen advisory team, and a couple physicians, nurses. We mocked up the room. We ran through a couple of scenarios. And again, the impact from the citizen advisory team was really helpful. Just a couple of pictures of the South Campus. So this is our main foyer. As you can see, it's large, open air concept. We really tried to embed a front of house, back of house concept into the hospital. So families and patients tend to congregate in the front of house, and then staff more so in the back of house. So we separate out the two flows of traffic, which has been advantageous. Within the rooms, 90% of our rooms are single patient rooms. Again, we heard loud and clear from our citizen advisory team and other members of the community that single patient rooms are beneficial. We have nourishment stations on our units. Our ICU family room has a large area for family members to shower and to store their belongings, because again, they're often here 24 hours a day. And then a couple of other features. So the inpatient room, for example, there's a cot that you can see in the corner there by the window where a family member can stay, and they can stay 24/7 if they want to. They're more than welcome to stay. This is the family nourishment area that we talked about. ICU room, so we tried to make the ICU room nice and large, because again, there are times where you're going to have multiple family members in a room, sometimes up to 15 or 20 family members. And then too, that couch converts into a cot so that the family member can stay, a primary family member can stay. So again, this is where I am in the emergency department, and Joanne will be talking a little bit later about our family presence during resuscitations. And so we give family members the option of either being in our code room there on the left, or they can remain in the family room, which is the picture on the right. So the family room has windows. You can look into the code room. You can see what's happening with your family member. It's a great space to debrief afterwards. It's nice and quiet. So when we have the team debriefing, our social worker, our nurse, our physician, we can all congregate in that room with the family. A couple other features of the South Campus that have helped us to spread the IPFCC message. We have free patient and guest Wi-Fi, although it doesn't always work, to be honest. But we've tried to implement that. We have an eSIM learning lab, and again, we try to make things as real as possible, and when we can, we try to use real patients. Electronic wayfinding and kiosk, volunteer wayfinders. We have a patient and community resource center, so we have a YMCA attached to the hospital, and within the YMCA, there's a resource center for patient and families. So that's the wellness center. We also have a wellness kitchen within the wellness center. We do lots of cooking classes, healthy eating type things for patients and their families. And then we have a spiritual care area. But with that, I'll turn it over to Joanne to talk about some of the specific examples of how we built in the supports and practices at the South Campus to implement our family presence.
Great. Thanks, Colin. So Colin's really talked about how we started off by building patient-family-centered care into the culture through the design, the construction, we also built it into our hiring process and our operational planning. But how did we really create this culture and then proceed forward to operationalize it? So the campus is on the foundation of 4 key pillars and operating principles that really set up all our relationships here at the hospital. You can see in the diagram we have wellness, innovation, collaborative practice, and then patient and family-centered care. We're integrated into all of the clinical and support service delivery models here at the campus. And so that means that we're creating a culture of healthcare that is designed around the patients and families and not the health system. We were very conscious of that. We were very intentional in the planning to embed patient and family-centered care right from the start. That meant we needed to set a clear definition and a vision for what we wanted to see here at the campus. We wanted to ensure patient family-centered care and family presence practices were built into the policies and practices of how care would be delivered. And then we wanted to make sure we onboarded and trained all the staff and physicians with that mindset, as our goal was a comprehensive site-wide implementation of patient and family-centered care for every patient, every provider, and every encounter here at the South Health Campus. One of the keys to successfully implementing both family presence and PFCC practices in general is that we really developed, and this grew over time, as a suite of practice support guidelines. I wish I had time to talk about all of them, but really want to focus today on certainly family presence, as well as I know folks are interested to hear about the family liaison for resuscitation program. Spend a little bit of time talking on that. So these guidelines, they really form the how to implement patient-family-centered care services, and we considered them almost the nuts and bolts because they set the expectations for staff to maintain that consistency of practice. The guidelines also, we didn't set up policies, we set up them as guidelines so that the clinical teams would have the flexibility to create the best environments that were specific to each of their patient and family populations. So the number one practice that we really implemented at South Health Campus was family presence and changing our perspective on what visiting meant for patients. This is really what we heard from our citizen advisory team in our early consultations that they told us they really wanted to see within this new hospital. So what did we mean or envision by family presence? Really, as was highlighted at the very beginning, that family and the primary support providers, they're welcomed, they're essential members of the care team, and they're not considered visitors in the lives of patients. I really believe that family presence is really a game changer in the adult healthcare world. It's a catalyst, and it can really be a foundational lever for moving forward with patient-family-centered care culture in general, and having families be full partners in care. So at the campus, family presence wasn't just about changing our visiting hours. In fact, we still have visiting hours, but they apply to visitors and not to family or those the patient considers their primary support persons as defined by the patient. And family presence isn't just about family or support people being able to stay overnight or room in, even though we have the lovely rooms. Family presence for us was about an entire philosophy and culture shift in the adult healthcare world. And it was really about welcoming families as full partners in care, because how can we expect families to be partners if they are not present as part of the encounters? So at campus, we welcome family and support people not only on the inpatient units, Colin's highlighted in the emergency department, and that includes all areas of the emergency department. In ICU, they're welcome during diagnostic tests and procedures, during outpatient clinic appointments, in our post-anesthesia recovery room, and during patient resuscitations. So when we started on this journey back in about 2010, 2011 to develop the actual practice guidelines, we knew that family presence and really the concept of open visitation was really becoming more common at that time. We knew it was an emerging best practice, but we wanted to ensure that we really understood the needs specific to our patients and families, and that those of our clinicians as we embarked on this journey into innovation of this practice. The key to ensuring that all our work was on target was to really gather input in the form of a needs assessment, and on the right-hand side it was kind of a template that we used to do a needs assessment. That's the particular one we used to gather the feedback from our citizen advisory team. But we also did needs assessments with our clinical design teams and our operational and planning and capital teams for the project. We conducted extensive literature reviews on looked at the many different visiting policies that we're developing across North America, and the Institute for Patient-Family-Centered Care guidance publication on changing hospital visiting practices and family presence and participation. That was really a foundational document that we used to help build our work from. And then we really just picked the best practices that were most supportive of patients and families and built our guideline off of that. So the aim of our family presence guideline is really to provide staff with information on how to support a family presence philosophy, the standards, and their procedures for persons spending time with and visiting patients at the campus. So here are the highlights of really our two hybrid guidelines that we have in place, and I believe the actual guideline documents are being made available to everyone on the webinar by CFHI in both English and French. And so we took the approach that family presence, as I said, was not just about rooming in or staying overnight, and it doesn't just apply to inpatient units. Some of the details, the family or The care provider is defined by the patient. That can change over time because you may have different family members coming and going and participating. That it's 24 hours a day, 7 days a week. All the different environments, wherever the patient wishes or desires that support. And we also built patient safety and IPFCC components into the guideline as well, because that certainly needed to be a priority first and foremost in welcoming family presence, as we heard from both our care providers and the patients and the families. And then you can see where we have our visiting hours. I just wanted to share some of the results to date, because I think one of the myths we had going into this, particularly from a lot of the care providers and the staff, was that if we opened up presence, there would be, you know, just all these families in around our inpatient units all hours of the night, and then there was going to be chaos and mayhem in the hospital on our inpatient units. So that was a bit of a myth, I think, that needed to be busted from the start. So our results to date, to give you that perspective, is we're seeing it ranges from only about 4% to 7% of patients who have a family member staying overnight, and that varies by unit and by patient population. I think the fact that family presence is welcome during the day really gives the family members the confidence that their loved ones are going to be looked after very well overnight. So a lot of families choose to not sleep overnight, even though that lovely space is available for them and they're welcome to stay. Family presence, we're seeing here at the campus now after about 2.5 years, it's highest in the cardiac units with around 5 to 6% of patients having their family stay overnight. ICU averages around 15%, but it's been as high as 24% of families stay overnight. But I want to make note that this isn't a perfect data set that we're pulling from. Because we're one hospital within a whole system here, we weren't able to have family presence recorded in our electronic electronic charting system. So we don't have a way to automatically record the number of families staying overnight. So we have a manual process to do that. I think our numbers have gotten better over the years, but it's not 100%. But that would be one piece of advice to others, is to make sure you're tracking family presence. As part of the data capture, it's important for inpatient units to have that data for emergency responses, if there's evacuations or outbreaks on units, to know how many families are staying overnight. It can help identify family needs for additional supports or for staff education. Family presence data can also be really important for evaluation and research purposes, so it's important to capture. Family presence data can hopefully down the road be linked and correlated with patient safety data. As we saw at the beginning, it contributes to reducing falls, medication errors. Is there a reduction in pressure ulcers? Will family presence be correlated to shorter length of stays and decreased readmissions or return visits to the emergency? Are some of the reasons why it's important to be capturing that family presence data up front. So I'm going to shift now and just speak very quickly about family presence during resuscitations. And there's a lot more we could share on this, but just some of the highlights. We recognize, as Colin said at the beginning, that family presence, it can and will look different in every different organization. And not all family presence policies or guidelines need to include family presence during resuscitation. So you need to be responsive to your local culture and whatever stage of journey you're at, and involve your local teams in that planning. Because it can't be kind of a one-size-fits-all or a top-down approach that these practices need to be in place. So we really had family presence and including supporting that during resuscitation built into the original guideline, family presence guideline, right from the beginning. And that really helped advance some of our practices here. But when we were delivering our education sessions around patient-family-centered care and family presence, it was really the staff who had said to us, we're supportive of this practice, but we would really like more in terms of skill and knowledge development in terms of being able to support that role. Staff to feel comfortable and competent to become that family liaison and look for additional training. And also our physician leads, they supported the idea of having family presence as long as there was a staff person who was designated to support the family during the code. So after a lot of literature reviews and research we developed, we couldn't find an existing program And so we developed our own program here in our own education program. So these are some of the elements on what the family liaison role is, to provide that emotional support and to provide information to the family in terms of what's happening in the situation, to guide and be responsive to the family through that experience. And that the family liaison isn't part of the actual code team, and they don't provide any direct care to the patient. Their focus is really to be on the family and ensure they have the information and the supports through that process. So the process for having a family liaison is assigned per shift. Typically this would be the social worker for a clinic or the unit that is primarily the person who would step in as the family liaison, but we don't have 24/7 social work coverage at the site, so we also needed a process to ensure that other staff were trained and designated on a shift-by-shift basis in each unit and clinic to step in. And so on the slide you can see that there are a number of different types of roles that can step in to be trained up and step into that family liaison role at any time. In terms of just evaluation so far, just to share some perspective on what we're seeing around families being present during codes. Right now, after a couple of years of this work, we're seeing about 25% of the codes here at the campus having families being present at them, because as you can appreciate, codes happen at any time or day of night and family aren't always present. And so right now 25% of the codes have family present, and at all of those codes there have been family liaison members there to support the family. So I'm going to hand it back to Colin just to share a little bit on his perspective on what some of the benefits are from a physician perspective of having families present during the codes, and also some of the lessons that we'd like to share in our experience here at the campus.
So as an emergency physician, I've worked at multiple other hospitals, and we would have family present during resuscitations now and again, but we didn't have a formalized process like we've put in place here. And there are definitely multiple benefits. So for the patient, you know, the patient might be unconscious. They might not be able to tell us their medical history, their goals of care, so what would they want to have done in a resuscitation. They might not be able to tell us anything about allergies. There's a whole list of things that we as physicians and the care team need to know from the patient that they might not be able to provide us with that information. So having the family there is really, really important to be able to get that collateral. I attended a code a couple of months back in our CT scanner, and so it was an outpatient who was just coming for a routine scan, had an anaphylactoid reaction to the dye, and this particular patient had come by themselves. And so you're trying to run this resuscitation in the CT scanner, and there's no family, there's nobody around to be able to give you the information, and all you know is that this person has come for a scan. You don't even have a chart because, again, the plan is for them to come in and out of that resuscitation. So now that we have family members present, and in the emergency department it does tend to be higher than on the inpatient unit, so Joanne quoted 25% of the time, but in the ED, family often arrives shortly after. So having the family there in the emergency department, we've definitely seen the benefit for patients. And then for families too, I think they feel that sense of not being able to do anything, to, you know, not being able to contribute, and yet their loved one is going through an acute life-threatening event. They want to be able to help. They want to be able to provide some sort of information. So having a liaison that can speak to that family member is definitely beneficial for the family, and we often focus all of our efforts on the patient, but we forget that the family is going through a pretty stressful event, so the family liaison is able to help the family person, the family member, go through this event. And then for the healthcare team, like I said, multiple benefits. You just get that input from another source, and when, again, you're dealing with an acute life-threatening event, little pieces of information can be critical, and oftentimes we're able to get that from family members. So the bottom line is that whatever you're at or wherever you're at in terms of implementing some of these PFCC strategies, there's always going to be obstacles. You know, in the physician world, there are always physicians who say that I won't do PFCC. They, you know, practice and trained in a more traditional environment where the physician tends to run the show and be the captain of the team. And you know, we ran into obstacles even here where some physicians just didn't want to participate in PFCC. But by having our practice support guidelines, by having it as one of our pillars and building it into the culture of the South Campus, some of these people that weren't necessarily buying into it initially have started to practice more CFHI policies. In terms of sustaining family presence, so it's great you put all this planning effort in, and everyone here went through an orientation when we opened up, introducing the 4 pillars of South Campus, and they could probably tell you what they were at the beginning. We really wanted to make sure we sustained that so that that effort continued on and had some momentum. And so we've determined a couple things have been successful in helping us to sustain the family presence at the South Campus, and part of that is leadership. So our executive leadership team here at the South Campus, it's really important for us to model correct PFCC behaviors, to make sure that we're practicing what we preach, basically. Continual engagement of patients and families is really important as well, and our citizen advisory team, you can see them there. They are very engaged, so we meet monthly. The CAT team is co-chaired by our senior operating officer and then a member of CAT. The members of CAT also sit on multiple committees, so our site leadership team has a citizen advisory member, the emergency department quality team has a member, and then again at least 10 or 12 of our committees have members as standing members so that we get that continual engagement. And finally, it's really important to measure and report how you're doing for PFCC. At least in medicine, evidence-based medicine obviously is really growing, and it's important to have data and report it out. And so we're fortunate in Alberta Health Services to have access to a lot of data in something called Tableau, which is a big database from our electronic health record. So we do lots of things within Tableau that we can report back to the site. And so at the South Campus, we have a yearly review, so you can see our yearly review from last year, and then we report on these parameters quarterly. So satisfaction with acute care within the hospital, we report this out to the site, and so we know on a regular basis how we're doing with respect to this. We also do unit-based feedback tools, so you can see in the bottom corner of the slide one of our units called the Rapid Access Unit. They survey the patients after the fact with telephone surveys to see how they're doing, and without that feedback you don't really know how you're doing. We do regular audits of some of our PFCC practices. We're currently involved in something called COACT, which is a big provincial initiative that is providing high-quality collaborative care, and as part of that we do NOD, name occupation duty. We have whiteboards in all the patient rooms. We do rounds where patients are active participants in the rounds, and we audit all of these things, and then we report them back to the unit on how they're doing. Joanne mentioned tracking overnight family stays. That's really important. And then we recently did a thank you card pilot project. And it's not just doing the thank you card pilot project, but also reporting back to individual staff members if they were named, how they were doing. At our leadership forum last year, we do a yearly leadership forum. We had someone from our knowledge translation department do about 10 focus groups on how leadership was doing at the South Campus, and really asking how are we doing with respect to patient and family-centered care. And so these focus groups were nurses, RTs, pharmacy, physicians. We got really good feedback on how we were doing and how we can improve on our PFCC practices. So in summary, the journey to family presence in PFCC is something that hopefully all sites across Canada are starting to embrace. I think the key is it's not an initiative or a project that has a start and a finish time. It's basically changing the culture and something that you embed on a day-to-day basis. To do that, it really has to be site-wide, and then it has to be built into your HR processes. So when you hire staff, you're not necessarily hiring for skill, you're also hiring for attitude as well. And so we embed PFCC questions into our interview process. I didn't touch on this earlier, but one of the keys that's really helped us is that we have a dedicated PFCC department. So at one point in time we had 4 FTE in our PFC department. Right now we're at 2.5, but really me as the medical director and the rest of our leadership team, we could not put in place any of these practice support guidelines off the side of our desk. Obviously we have lots of other issues with capacity and things like that to deal with, so it's really important to have dedicated resources. And then again, putting them out there as guidelines. readily accessible. Staff can easily see it, they can view it, and it's basically part of the expectation in their job that they're going to start to do these things. Supporting the staff through learning opportunities, we do PFCC deep dives in our emergency department and in our units. And then because the CAP team members are on so many committees, we really try to encourage them to share their stories at these meetings. So we try to start our meetings off with the patient story. And then, like I pointed out, it's great to do PFCC, but it's also really important to measure and report it back to your site. How are you doing? What are your areas that you need to improve on? And we found by having an annual report and then updating some of our data parameters quarterly, we can really provide the staff the feedback that they need to feel the success that PFCC is working or identify areas where we need to do a better job. So that concludes our presentation. Again, thanks for the opportunity to help spread the message of what we've done here at the South Health Campus.
Well, thank you so much for sharing your insights and your experience on what family presence looks like at South Health. I'd like to pause for a few minutes as we give an opportunity for folks on the line to pose any questions or reflections for the team at Alberta Health Services about their journey. And if you have questions, please type them into the chat box on the right-hand side of your screen. And I see folks are typing, so I'll just start the questions by a question we've received from hospitals who are contemplating their journey and the role of family presence policies and family as partners in care. And Colin, you mentioned that you had up to 15, 20 members in ICU at times, and when we did our scan, which Christine will talk about a little bit later, across Canada and current visiting hour policies and family presence policies, there's often a limitation for the number of family members that can be present, and understand some of the rationale behind that. But maybe you could just share a little bit about how you onboarded and supported your staff and providers to be able to support, a number of family members being present. Sorry, Joanne or Dr. Costello, maybe any thoughts or reflections you could share with us?
Can you hear us? Are we mute?
You're back on. Thanks very much, Joanne.
Okay, go ahead.
So yeah, we had the advantage with the infrastructure to be able to build large private rooms that could accommodate large amounts of family members, so that certainly helps. Definitely if you're in a small room with curtains and it's not very private, you can't accommodate that large number of family members. So it was easier to do it here. But really it also comes down to the staff having a sense for the situation, and that sometimes it's not applicable to have that many family members, in which case we use a system of trading off where you always have one key family member as sort of the go-to liaison for the care team, and then depending on the situation you can either accommodate that large family or it has to switch in and out just depending on the clinical scenario. And then eSIM was helpful too. So again, in the process of setting up the site, by doing various scenarios and running codes within the various departments with our simulation team, we were able to see, okay, what areas of the hospital could accommodate large groups of family members, and what other areas was it not going to be a success. So we were able to practice that ahead of time.
That's very helpful. Thanks, especially sharing where can we do this, and how do we provide opportunities for simulation to work through what it will look like in the experience for everyone. Very helpful. Thank you. A couple other questions coming in. One comes from Tegan King, saying thanks for the presentation. She's curious about the process of decision making for the changes to the physical space. You had mentioned a front and back of house, and was this something you would consider a co-design process?
So the front of house, back of house concept, I think really that, it probably predates both Colin and I on the project, but really that was brought in from the architects and the designers through the actual capital planning process. It was really looked at as best practice in modern hospital design now to separate that front of house, back of house flow. So one of the really, the benefits for families and patients is it just changes the overall atmosphere within the hospital. When the bulk of equipment, when the bulk of staff are moving throughout the hospital in back of house, it leaves the front of house where the families are moving through a very calm, type of environment. The other thing that the back-of-house concept allows is that patients that are being moved from rooms or being moved from emergency or OR throughout the building, they're being moved through private spaces. They are not being moved throughout the public corridors. So it maintains that privacy and dignity for the patients, and that the family members are welcome to go along through those back-of-house corridors with the patients. So they're able to stay together and out of the main public view, and I think that really, respects the privacy and the dignity of patients as well. So that was really all part of the planning process and the visioning for how the campus was going to be designed.
Great, thanks, Joanne. And I see some more questions coming in, and please continue to type in your questions as they come. If we don't get a chance to discuss and respond, the speakers to respond to all your questions today will circulate the questions and some responses as part of the post-webinar materials. I did want to take a chance to take one more question at this point before we move on to Bev Johnson, our next speaker. And that question comes from Lisa. And the question is, how at Alberta Health South Campus are the guidelines conveyed to patients themselves that their family members are welcomed and able to stay with them overnight?
Hi, Lisa. Good to see you online here. The guidelines themselves, the documents themselves are internal documents, but we have a family welcome booklet that is made available to all families when they're getting prepared for surgery, when they're doing their pre-op assessment. So hopefully our goal is to get that information to the patients and families so that they're well aware that they're welcome ahead of time before coming into the hospital. It's also available on our website in terms of the information around visiting and welcome families. It is available to patient families on the website. The units, if you arrive at the hospital and you don't have that pre-information, a lot of the are now doing a welcome orientation where they go over all of that information and they explain that families are welcome to be there and what some of the guidelines are, what some of the amenities within units and within the hospital. So they're all part of that welcoming process. We don't have restrictive hour signs on some of the doors, so we don't have that as a barrier, but we do have a lot of the doors are locked, but the families are able to scan and to come into the units, but they're just locked for security of the units, but families are able to buzz in and out quite freely. So those are some of the ways that family members find out about that information.
Thanks, Joanne, and thanks to everyone sharing your questions. Keep them coming, and we'll respond to them either live today or following today's presentation. At this time, though, I do want to turn things over to Bev Johnson, President and CEO of the Institute for Patient Family Centered Care. Thanks so much for being with us, Bev, and please go ahead.
Thank you so much, Maria, and it is really wonderful to hear the excellent work that's happening in Alberta and at the South Health Campus. You know, I think it speaks to the importance of partnership, that with that project right from the beginning, there was true, meaningful, valued partnership with patients and families and citizens, and that you have been able to carry it through. Just congratulations to all of you. The Institute for Patient and Family Centered Care, I hope many of you know about us. We are based in the United States, near Washington, D.C., and we value our partnership with Canada. I'm just back from our in-depth seminar, and there were many organizations there from Canada, and it's wonderful to promote this learning above and below our borders. We define patient and family-centered care as an approach to the planning, implementation, and evaluation of healthcare that's grounded in mutually beneficial partnerships. And there are four core concepts: respect and dignity, the sharing of information with patients and families in ways that are useful and affirming, the encouragement and support of patients and families to participate in care and decision-making at the level they choose, and collaboration, both in clinical encounters and in improvement, as improvement partners. And we are thrilled beyond words that Accreditation Canada has taken this definition of patient and family-centered care and embedded it in all standards for Canadian healthcare organizations. They're calling it client and family-centered care, but the same concepts of mutually beneficial partnerships, and with these 4 core concepts. And I think these core concepts guide our discussion today in changing the concept of families as visitors. For a very long time, we've been concerned that this change was not happening, that we, with all the advances in patient and family-centered practice, there were still, in North America and beyond, many hospitals that still labeled families as visitors and had restricted policies. So we created the international campaign, Better Together, Partnering with Families, and it's certainly an honor to partner with the Canadian Foundation for Healthcare Improvement in this work. We value their insights and experience and the work that they're doing across Canada, and we are actually sharing it to inspire work in the United States. So in 2014, in June, we formally launched the international campaign to change the concept of families as visitors in over 1,000 hospitals by 2017. And we're very careful when you're trying to change the culture of an organization. Language is very important. And so this campaign is not really about open visitation, because that's still labeling families as visitors. And if we really want to embrace family presence and participation and enhance safety, quality, and the transitions of care, we've got to view families in a different way. So as we are trying to help the field understand maybe a subtlety in this work, but I think many folks have felt that if they have open visitation, they've done what is needed, but that's not enough. When we label families as visitors and impose restrictions, it really undermines their ability to be fully engaged in care planning, decision-making, and care processes. Some of you know, I see some friends on the wonderful list of people joining the webinar today. My mom's 102, and certainly that is a blessing. And another blessing is that she's very mentally alert. But when she's in hospital or in the emergency department, she needs the help of a care partner, whether it's me, my brothers, or someone else in our broadly defined family. And so I don't view that I am a visitor in her life. That's not my role. My role is to be a care partner, to help her in her care. So if we label families as visitors who are not insiders like I am to healthcare, they don't understand that they have a really important role to play in the care, in the transitions to home from hospital care, and in community care. And I think there's a lot, and particularly for the nursing and physician practice, that there's a commitment to evidence-based practice. Well, there's absolutely no evidence that suggests that labeling families as visitors and enforcing restrictive visiting hours is the right thing to do. What we can say, though, is that eliminating restricted visiting policies and supporting staff, and this is a key concept, that we support staff in learning how to welcome and proactively partner with families and other care partners, whomever the patient defines as that's going to be helping them with their care and decisions about their care. And for leaders on the call today, this is really a smart business decision for your organization. It can help you improve the experience of care, reduce harm, and improve the transitions of care. One of the things to look at as you're thinking about changing the culture of your organization to support family presence and participation is to look at what is your signage, what message does it send to patients and families, and I would argue to staff as well. I've taken these pictures over the years, and I could give you 200 or 300 others that are just like it, that have the same messages on them. They may look a little different, but they're conveying this sense that you're a visitor, sometimes in English or Spanish or French. When I toured a hospital recently in our country, I toured with the chief nursing officer and a facilities person, and they said first we took down all the obvious signs, and then we realized there were a lot of subtle signs that didn't convey a sense of welcome and proactive involvement. An example was at the Children's Hospital, where at the pediatric intensive care unit, it said that they had open visitation except for when rounds were conducted and when nurse change of shift happened. And then in very small type below, it said families could visit at any time. And they thought that was okay. And as we talked about it, I said, think again about what the messages families are getting from that sign. In that, one, they're labeled as visitors, not the key partners and decision makers for their child's health care. But it also sets up a tone that they're not encouraged and welcome and respected as key members of their child's health care team. And they often would push back and say, but we make exceptions for family members. You want to create the positive, upfront, welcoming tone from the beginning. And I think that's what this hospital, Anne Arundel, has done. They took a year to thoughtfully and in an in-depth way work with each department to change the concept of families as visitors throughout their hospital. And so they have pineapples. They don't grow pineapples in Annapolis, Maryland, but it's a symbol of welcome. And they talk about this is according to patient preference, because some patients may not want their family there. And this is all about respecting the choice of patients. And that they also are explicitly conveying and helping teach the public and the families who come to their hospital about their role. And one of you asked a question about how you can do that through your websites and through guidelines, through handout materials, but they're conveying the role of families is not just to be there, quote, as a visitor, but really to provide care and support, and always welcome 24/7. Here's another way this children's hospital is very proactive in getting that sense of partnership. You don't see the words visitors here. They have guidance about how you can partner with us. When they talk about the healthcare team, they say you are the most important member of your child's healthcare team. And then they talk about doctors and nurses and respiratory therapists, etc. And here's another sense of two other hospitals. The hospital on the right used to have a whole board of when families could visit, and now simply they say, welcome to 2 North. So patient and family-centered care is about working with patients and families, not just doing things to and for them. That's the simple definition, but I think it gets at the spirit of what we are talking about here today. And when you think about it, you can't work with families if they're locked out of the clinical units. And when my mom was in the hospital a year ago, while she's very alert and can track most of the time after major surgery and on pain medications, it was hard for her to participate actively in her care and really remember it. And so I could take notes and then talk to her as she became clear mentally, and I was going to be the one who would be the continuity to help her make that transition to home. I think when you look at it, this change in policy and practice to respect patient preferences and welcoming families is fundamental to all of those core concepts of patient and family-centered care. It's respecting patients and families' preferences. It's sharing, putting them in a position where you can share useful information with them. And you are explicitly, by welcoming them, you're encouraging their active participation, as Maria said at the beginning of the call, really seeing them as allies and partners for quality and safety. And that you, by having them with you, not having rules that govern the relationship, that you are collaborating with them, and that they're partners with you to make this change in policy and practice. In our country, we have done, at the American Hospital Association, a recent study. It's a landscape study of looking at patient and family engagement across all of our hospitals. And over 1,500 hospitals completed it. And I think here is some very useful data that was just published, and it's also in a British medical journal. I think that that article probably is a resource for all of you. But in hospitals with unrestricted access to patients by family and partner across all units compared to just some of the units or no units, their satisfaction scores on HCAHPS is 3 points higher. This is huge. That it is, their patient satisfaction scores are better when there is open access for families. We could go into much more subtle discussion of this, but this is just basic baseline study that we have now available in our country. And I think you're going to be able to have, after the good work of the Canadian Foundation for Healthcare Improvements, we're able to generate additional data. In terms of a new article that I think might be helpful for you as you move forward and begin to further change policy and practice, this was published in the Journal of Nursing Administration early in 2015. And it talks about their process, which I think is a very good process for changing the culture and practice in there. This is at Duke in Durham, North Carolina, and it's an academic medical center. When they first revised the policy statement to be a family presence guideline statement, staff had many concerns, all the myths that Joanne talked about, that for privacy laws it would be a burden to nursing staff, it would be a burden to families, just all the things we always hear. And I think what's interesting, leadership said, we are making this change. This is the right thing to do. And just 4 months after they'd implemented the new policy, 87% of the staff who completed the survey felt that they were in favor of the new policy. And I think one of the things that helps this change is we get, particularly nurses, out of the role of policing this policy and having to adhere to rigid rules. I think they discovered also, as we all have, that patient stories are very important to the process. One of the things that we have learned in working both in Canada and the U.S. and in other countries, you cannot change this policy and practice if you simply take down the signs. You really must support staff for change in practice. And we believe respect and dignity, that core concept of patient and family-centered care, is not only for patients and families, but for staff as well. And for many of them, they don't have the skill set. They weren't taught to communicate and create that tone of partnership. They weren't taught how to welcome families from the very beginning in an encounter, to be really part of the process. So this list of core skills and competencies that staff should have, I think you could partner with your patient and family advisors, with your staff leaders and your clinicians to help build these skills, and it will build the comfort level as well as the competence of staff to truly welcome and support families in this process. But it shouldn't just be a quick change, but to work in a collaborative way to address staff concerns and to build on their skills. So we believe as you move forward with patient and family-centered care, and I think Joanne, you were saying the very same thing, that this is really a first and major step to building comprehensive partnerships with patients and families in hospital settings. That you build on this change around, quote, visiting policies to support family presence and participation, but then you support staff in learning how to do bedside change of shift collaboratively with patients and families, to do rounds collaboratively with patients and families, and even that is teaching academic rounds, that they are involved in the transition planning process, and that end-of-life care planning and decision-making is also a collaborative process. That's core to the work that you do. So thank you very much for letting me be part of it, and I want to turn it back to Maria now.
Thanks so much, Bev. So I just wanted to share, I think you've heard from South Health Campus and from IPFCC sort of their motivation for really focusing on family presence policies and the practice of family presence and participation. I wanted to share a little bit more about why CFHI has chosen to partner with IPFCC on this campaign to help spread family presence policies across Canada. And before doing that, I wanted to acknowledge that the Better Together campaign was started by IPFCC, and it's supported by a number of U.S. partners, which are identified on their website and our website. And the CFHI was the first Canadian partner, and we're also thrilled to have the support from 12 other organizations in Canada, including 6 national organizations: Accreditation Canada, the Canadian Patient Safety Institute, Patients for Patient Safety Canada, Canada Health Infoway, the Canadian College of Health Leaders, and Patients Canada. In addition, we have a number of provincial organizations, quality councils, and professional associations supporting us, including the Registered Nurses Association of Ontario, RNAO, the Manitoba Institute for Patient Safety, Saskatchewan Health Quality Council, the Health Quality Council of Alberta, and BC Patient Safety and Quality Council. So just, I think it's a real recognition of what I'm going to talk about next, is that family presence policies and partnering with patients and families to improve care and to improve the performance of our system is really grounded in the mandate and focus of these organizations and in the evidence, as Bev said. So much of our work at the Foundation is grounded in evidence that comes from work that's been done by Dr. Ross Baker and Jean-Louis Denis, looking at high-performing health systems and what are those key attributes we see in high-performing health systems, systems that are patient-family-centered, that there is good value for money, that are responsive to population health needs. And so we worked with them to turn those key attributes of high-performing health systems into levers for improvement, and that's what you see on this slide here. And just wanted to share our connection that the family presence policies really touch on all of these levers, about creating supportive policies within organizations, about creating that organizational capacity and culture for learning together and for partnership, that high-performing health systems do engage their patients and their citizens in their work to improve the experience of care, the outcomes of care, the use of our resources within healthcare, and it's about how we provide and engage frontline providers in creating an improvement culture, and I would say a culture of partnership is key to a culture of improvement. So thank you to all the partners, to IPFCC for spearheading this campaign, and to the U.S. partners and our Canadian partners for really helping to support and promote and support organizations in joining this campaign as we move forward. So I think we've talked about this throughout, but just wanted to share that really, experience of organizations and teams and emerging, research evidence demonstrates that when we collaborate with patients and families, we see improvements in direct care that is more patient and family centered, and in improvement in the system and the performance of our system. So family presence and policies are one concrete example of how collaborating with patients and families improve both care and system performance. Other speakers have talked about the value proposition from the perspectives of patients, families, staff, and organizations, and we'll hear from a family member and their perspective at the end of today's webinar. So without further ado, I want to hand things over to Christine, who's going to share a little bit about CFHI's work that we've done to understand the need for the Better Together campaign in Canada and how we can help spread family presence policies and practices.
So thanks, Maria. And in the early stages of our partnership with the IPFCC on this campaign, we wanted to better understand the opinion and perspective of Canadians, both working within the healthcare sector as well as the general public. And when both of these groups were provided with the definition of family presence, we found that 9 in 10 Canadians supported the principle of family presence. This was true both within the healthcare sector as well as the general public. And we did want to acknowledge, just as Bev and Joanne have spoken to some of the apprehensions or concerns of the healthcare providers, these are quite real in terms of their perceptions and the concerns that they have, such as achieving the balance of not stressing patients with unwelcome visitors, finding appropriate times for loved ones to be involved, as well as ensuring adequate resources to deal with this change. Another question we had was about the state of visiting hours within hospitals in Canada. So we undertook a baseline study to better understand visiting policies across Canada. And we adopted methodology that was used in the study conducted in 2012 in New York State. And we chose to study acute care hospitals and in general medical surgical units, as this is where most of care is provided. And we did this by using an existing database from CFHI called Your Health System in Depth. And we took the hospitals that were classified as large. And CFHI uses the peer group methodology that helps identify hospitals that are reasonably similar to classify these hospitals as large. And this classification is based on the volume of patients and the complexity of their care needs, and not the number of beds. And we were out in the field conducting the survey between February and April of 2015. So this report will be released next week, November 10th, and I will be providing a brief overview of some of what these initial results were. And again, you'll see our question at the top, wanting to better understand the state of visiting hour policies in Canada, and 114 acute care hospitals did meet the definition of large. When in certain provinces or territories there was no large hospital, we also included the next largest hospital. So in some instances, such as the territories, smaller community hospitals or medium-sized hospitals were included. So hospital websites were reviewed by reviewers to better understand the openness of hospital visiting hour policies, as well as the availability and usefulness of this information. These were evaluated using 10 question score sheets. And based on these score sheets, hospitals received 2 scores, each between 0 and 10 for the openness of the visiting policy and the availability and usefulness of website information. When we're talking about openness, we're talking about things like the visiting hours, the time of day that's suggested for visitation, and if there's any indication of flexibility that's permitted outside of visiting hours. When we're talking about the availability and usefulness of information, we were looking at things like the number of people allowed to visit at one time, if there was guidance on child visitors, and if there was instructions on hand washing. So in general, what we were finding is that there's an inconsistency of policies across Canada, ranging from very accommodating, which would welcome people 24 hours a day, to not at all accommodating. In some cases, there were 2 hours of visitation that were prescribed by hospitals. morning and evening hours are frequently limited for visiting and provide the opportunity to better welcome family members at those times. We did notice that open and flexible visiting policies do exist, but they're not common at this time, and their implementation may not be consistent across hospitals. In fact, many hospitals within our study, 23%, use language to describe their visitation policy as open, 24/7, anytime, and flexible. However, it is important to know that there's still some confusion with families when it's not always clear if open, flexible, or anytime really does mean that visits beyond visiting hours would be permitted. And our last observation is that the information posted on hospital websites provides limited guidance for families and visitors. We'll take some time briefly just to look at the openness of the scores by province. In this table, you can see the number of hospitals surveyed by province and the average openness of scores in each province. You'll see that the average is 4.64 on a 10-point scale. And this score means that, in general, existing hospital visiting policies are only marginally accommodating. However, this score should be interpreted with caution because there was a wide range from 0 to 10, and variability was seen both across and within provinces and territories. When we're looking at the breakdown of hospitals by score, you can see that 2 hospitals that we surveyed received a perfect score of 10 for having very accommodating visiting policies. 3 hospitals received high scores of 9, and 25 hospitals scored 8, the higher end of accommodating. What this means from our study is that these hospitals either had an open visiting policy or provided for at least 14 or more visiting hours per day. This included at least 2 hours of visitation in the morning, and these are the organizations that we will feature by name in our report. Now we'll turn our attention to the second scoring sheet where we are evaluating the availability and usefulness of information. And we'll start by looking at the provincial averages for this metric. You'll see from the table that the overall average of all provinces on the availability and usefulness of website information is 5.29 on the 10-point scale. This tells us that website information is only somewhat useful. And again, exercising caution in interpreting the results due to the wide range of scores between 0 and 9 and the variability of scores both across and within provinces. And you'll see from this breakdown by score that no hospital received a perfect score of 10 and only 3 hospitals received a score of 9. Over 35% scored between 7 and 8, which was considered having useful information. And it is important to know that more than 90% of all the hospitals reviewed actually did post some hours on their visiting site. And they make things easy to locate, view, and print information on visiting hours. However, low ratings on other parameters, such as safety, suggest the need for improvement in the details communicated to potential visitors. So in summary, and you will see this in the report released next week, we found that more than 30 Canadian hospitals have accommodating visiting policies, and this is a step in the right direction. It's also very positive that nearly half of the reviewed hospitals have policies that are at least somewhat accommodating. Consistency in visiting policies could be helpful in reducing the disparities in care experiences and eliminate the need for staff on certain units to make exceptions. And further improvements could be had in communicating the information that is relevant and pertinent to families and visitors.
Thanks, Christine. And so more details about that approach we took to looking at hospital visiting hour policies as available to the public via websites, and follow-up phone calls will be available next week. Just wanted to reflect on what we saw. Is certainly an opportunity for improvement in how we communicate. As Bev said, we look at visiting hours because that's sort of the current state right now about how it's expressed, but really we're looking to encourage and support the adaptation adoption and the spread of family presence policies, and to support patients' family members being welcomed as partners in care and the practice elements of that. So we're really excited to, as we work with IPFC and partners, to mount a supportive campaign for organizations to examine their visiting hours policies, but more importantly, even the role of family presence policies in their organizations. I'm going to welcome some questions or comments. If you have them at this point, you can type them into the box. I also want to return to a previous question or comment that came in earlier. And it came from Elizabeth. And Elizabeth was asking about, and perhaps Joanne or Bev could share your experience about, the question is about how incorporating patient cultural practices into care, and any experiences, lessons learned, suggestions for that from your experience. Perhaps you could start with Joanne.
Hi, it's Joanne. I'm happy to kind of jump in and start that, the answer to that. Absolutely. Within the campus, we were very conscious, and a lot of it had to do with the feedback and the preferences expressed by the patients and families we partnered with in a variety of different cultures. So we were very conscious of that, planning it into the facility. We do have appropriate cultural spaces. We've built it into the infrastructure, for example, for smudging ceremonies to have reverse, I don't know the correct technical term, the reverse airflow to enable that to happen in key locations, not throughout the entire facility, but certainly in key locations. We do not have full-time on-site cultural helpers, but our patients and families do have access to them through our services throughout the Calgary area, and they can come to the site as necessary. So we do incorporate that, and our staff also are very attuned to taking various cultural competency training programs that we have available throughout the province.
Great, thanks, Joanne. Beth, did you have anything you wanted to share or add? Okay, thanks. At this point, we'll move into talking about the Better Together campaign itself and the opportunities for sharing experiences, posing questions, learning from organizations who may be at a different point in their journey in patient family-centered care, and particularly in developing and implementing and supporting family presence and participation. I'll turn things over to Christine.
Yeah. And today, I guess, really does mark the transition to sort of the next phase of our partnership with the IPFCC, and I guess an unofficial launch of the campaign in Canada. And it really is CFHI encouraging Canadian hospitals to consider the process of implementing family presence in collaboration with patients and families, seeing this as a practical step towards delivering more patient and family-centered care. As you'll see on your screen, there are sort of 4 different steps or elements to the campaign, really beginning today with the launch and awareness activities. What we're offering in terms of this launch and awareness, you'll see that our website has changed within the Better Together platform under what we do, and we'll certainly circulate that in our follow-up email. So you'll see that we have new website content that's been developed. We do have a video that is now on our website promoting the idea of family presence and the benefit to patients, families, and providers. We've also launched an ad campaign, and you may be seeing that in some of the publications such as Longwoods and Hospital News. And our baseline study will be available on our website on November 10th. As part of our launch and awareness, I'll skip through these. I think it's important to talk about the pledge. And this pledge, what we're hoping to achieve is that and you will find this on our website, you'll see that it is incremental in nature. So it doesn't matter where you are within your journey. Really at the beginning, we would be inviting people to undertake the initial leadership action steps in reviewing your policy. If you've already committed to doing that with your leadership, with staff, with patients and families, we'd encourage you to continue on that journey, and that really brings us to the number 2, developing a family presence policy that enables patients to designate one or more partners in care. And then beyond that, moving to number 3, and this applies mostly to individuals who have implemented the family presence policy, we're very interested in the quality side. And Bev and Joanne have shared some metrics that speak to the idea and the notion that this does improve quality, and we would like to explore that with all of you and those interested in pursuing the measurement aspect in particular. Part of our support has been around developing a change package, and Joanne talked about really cherry picking the best ideas and the best resources. So we've tried to do that as well, and we've developed a change package which takes some principles of quality improvement and change management and all of the excellent resources that are included on the IPFCC website. And we put those into a change package that offers a supportive and incremental stepwise process. We do know that this is about culture change and not a flick of the switch, but we're hoping that the structure will be supportive to those who are undertaking this change. And you'll see, you of course are on the first webinar. We have a second webinar that we will be offering in February, and we are in the process of developing case studies to go along with those so that we can better understand what family presence looks like and how it's adopted and applied in different settings. And finally, as we're moving into 2016, we will be developing an online network, and this is really a network where we accelerate healthcare improvement through connecting individuals who are working on common ideas and priorities, connecting these to quality. So we will keep an all teach, all learn principle and offer things like affinity calls where you'll come to common barriers, common challenges, or common successes that you'd like to exchange information with those who are experts in the field or have more experience doing it, and we look forward to co-hosting and facilitating those. So more information will become available as we continue to roll out our programs, and again I'd encourage you all to check out our website as we've just I guess entered into the next phase. So I will now turn things over to Angela Morin to share her experience on family presence and really present the opportunity for champions who may be in organizations in terms of supporting and getting buy-in from others. So Angela, over to you.
Good afternoon, everyone, and hello. I've really enjoyed the presentations today of just the wonderful work that's been happening in patient and family-centered care. It's really inspiring. I am a believer in the adage, which I think Maya Angelou is credited with, that people may forget what you did, but they will always remember how you made them feel. So, please close your eyes. I'd like you to remove your healthcare provider, staff, leader, advisor hat for a few minutes and just close your eyes. Picture someone you love. Perhaps it's a spouse, a child, a parent, a friend. You are holding hands. They are sick or injured, scared, vulnerable. They are lying in a hospital bed in your organization, your hospital. They hold your hand tighter and they say, please do not leave me here alone. Please do not go. How do you respond? Do you say, I have to go, visiting hours are over, and leave? Do you say you will stay and ask your coworkers to make an exception to the visiting hours rules? Or do you say, because you can, I will be here as long as you need me? Getting rid of restrictive visiting hours, having a patient and family-centered family presence policy is about being compassionate and respectful of patients' wishes and relationships and allowing loved ones to be there as long as they are needed and involved in care as long as they are needed. But it is also about patient safety and quality of care. If your eyes are still closed, by the way, please feel free to open them. At 57 years of age, my mom was diagnosed with colorectal cancer. Once she was diagnosed, everything happened really fast, and before we knew it, she was waking up from a surgery with a colostomy and a long road of radiation and chemo ahead. The night after surgery, we left when visiting hours were over and returned the next morning to find Mom distraught. It had been a bad night, and I vowed at that moment that she would not spend another minute alone as long as she needed someone to be with her. This decision to not leave when visiting hours were over was met with mixed responses by the staff. For the most part, they were tolerant, but not terribly welcoming. Others embraced it and made me feel comfortable. I got her water, which was out of reach. I comforted her in dark moments. I stopped her from pulling out tubes and IVs, and I talked her out of getting out of bed in the middle of the night and trying to make a run for it. I was there to hear the doctor's instructions and ask the questions that we needed answered. I was there to be part of her care team, and I held her hand. I have to say that I have a lot of trouble comprehending how anyone would actually think that an organization or a policy or a complete stranger should have the right to tell me that I, as a patient, cannot have my loved one with me when I need them the most. I actually find restrictive visiting hours to be an archaic, system-centered practice. Different hospital, 10 years later. My daughter, who was 22 years old at the time, had surgery to repair a broken pelvis. The night of her surgery, I was asked to leave, but was able to negotiate a few more hours with her. The nurse let me stay. But when the shift changed, the nurse came in and insisted that I leave. She threatened to call security. So I left to avoid making a scene. When I arrived in the morning, my daughter was very upset. They had removed her catheter the night before, and she had to use the washroom during the night. She had rung the call bell. No one came. She was afraid she was going to wet the bed and was doped up on pain meds, so she got out of bed and started to the washroom. The nurse caught her and scolded her for getting out of bed. After all, she could have fallen. That night, I stayed. No one forced me to leave. Sudden policy change? Staff change? Fear of me going ballistic, maybe? No idea. But I was allowed to stay with my daughter. I got her the bedpan, held her hair when she vomited, repositioned her pillows, and I held her hand. Having a family presence policy in place means patients can partner with staff in determining who or if they want someone to stay with them, and relieve staff of the challenge of breaking the rules and circumventing policy just to do what is the right thing to do. This past winter, my dad had to have a life-threatening cardiac procedure, yet again in a different hospital. In preparation of the day, my mom looks at the hospital website and sees that there are set visiting hours. From that point on, she becomes so stressed, not just about the surgery, but about the inevitable confrontation she has to prepare for. There was no way, if my dad needed her, that anyone was going to make her leave that hospital. My parents have been married over 50 years. They are best friends. How could anyone think that forcing my mom to leave my dad's side, to let go of his hand if he needed her, was the right thing to do? Knowing an organization has a family presence policy that allows families, as defined by the patient, to partner in the care of their loved one is a huge comfort, provides peace of mind, and reduces anxiety and stress for everyone involved. Kingston General Hospital, where I am a patient and family experience advisor, has changed their visitation policy a few times over the years. It has evolved. It went from restrictive visiting hours to families welcome 24 hours a day. It went beyond changing the language to become more inclusive of patients and families, to changing the entire intent of the policy. Like Alberta South Health campus, KGH is committed to creating an environment supportive of patient and family-centered care and positive health outcomes. And the family presence policy is there to support and facilitate that. This is not about allowing visitors to run amok, or, as Bev said, just getting rid of visiting hours. It is about dignity, respect, communication, participation in care, decision-making, information sharing, and collaboration. It is about changing the concept from family as visitor to family as partner in care, regardless of what time of day it is. I really hope that organizations will embrace the Better Together campaign. It provides important guidance for staff and families, proven strategies for educating staff and for changing policies. And for those struggling to get buy-in, it will lend support and provide data and measurement ideas. There are champions out there just looking for the commitment and support to make this happen in their organization. The Better Together campaign is here to help, and the time to do it is now, because we are better together. Thank you so much for giving me the opportunity to participate today. I have really enjoyed the information. Thank you.
Thank you so much, Angela, and thank you to Bev, to Dr. Costello, to Joanne and team from AHS, and the CFHI team here. I have nothing to add. You've summarized it just fantastic, Angela, why this is truly about why, for everyone, we're better together. You're going to see, thank you everyone for joining us, and we look forward to continuing conversations and opportunities to work together across the country to improve things for everyone involved in healthcare. You'll see popping up on your screen right now a survey, a poll. Please, if you have a few moments, take the time to give us your feedback. We really look at this and it helps inform our planning for delivering programming here for you. This wraps up and concludes today's session. I thank you again for joining us and wish everyone just a great rest of your day. Bye for now.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.
Et change bien, oui, change.